you, Ange.
Thanks so much, Brooke. Brooke, if you notice people with their hand up in the
Yes,
chat, just feel free to interrupt me.
I will. I will.
Um,
I will.
the presentation definitely won't go for the whole hour, and it's always nice when these are a little bit interactive and people are able to ask questions so that I know that I'm meeting your needs, because this talk is really just about information provision and making sure that you get all the information that you need about egg freezing. So before I start, I wanted to acknowledge that I tonight am meeting with you on Awabakal land, and I wanted to acknowledge the traditional custodians of the land that we live and work on, and recognise their continuing connection to the land and waters, and thank them for protecting the coastlines and all of the ecosystems for many, many, many years prior. So I pay my respects tonight to elders past and present, and I wanted to extend that respect to any First Nations people who are present this evening. We don't need to hear any more about me because that's quite enough. Tonight, I wanted to just give a little bit of background, some facts and figures about fertility and age, why people would consider egg freezing. I wanted to talk about what's involved in an egg freeze cycle, just to provide you with some extra information. And then I've structured at the end some frequently asked questions that I get when I see people for a fertility conversation about egg freezing. I guess you can't have this conversation without talking about clinic success rates, because that really does make a difference to long-term outcomes. So I've included those at the end, and then we'll just open for discussion any questions in a really informal way that people might have. So reproductive trends are changing over time. We're noticing delayed parenthood. The average age of first-time mothers in the 1960s was about 26, and that's increased to almost 30 by 2023. And it's continuing to increase. And 1 in 5 women now are delaying their first pregnancy until after they're 35. We can see that from the figure on the left, that the rate of women having children in their 20s is continuing to go down, but a continued increase in women having children in the 30 to 34, 35 to 40, and then 40 plus brackets. The other thing that's changed over time has been the definition of infertility, and that's to become a bit more inclusive. So it was felt that no one should be denied access to treatment or discussions about treatment for their relationship status or their sexual orientation. So all of the main bodies that deal with infertility in Australia and New Zealand have broadened their definition to be much more inclusive. Annoyingly, as women, there's no way around the fact that age remains the single most unchangeable influence on our chance of achieving a pregnancy. We're born with all of the eggs that we'll have to use in our lifetime, and we've actually lost a lot of them by the time we're born. We lose them in the in utero timeframe. And the quality and quantity of the egg supply does seem to start to deteriorate further in our mid-20s, and then speeds up a little bit at the age of 35. So the chance of having a natural pregnancy per month of trying at 22 is 25% per month, and it drops down to 15% when you're 36. And then for each month that you try to fall pregnant when you're 40, the chance of achieving a pregnancy is about 5%. And this does have to do with the egg number, but more importantly, it has to do with the quality of the eggs. Miscarriage does also become more common. So people are starting to get increased awareness of this. I think when I was at school, all of the conversations were about how to prevent an unplanned pregnancy, but we weren't really educated on our own reproductive trajectory and what it meant to try and have a career and babies and all of the things that we're supposed to be able to do in a single decade. And with that increased knowledge, we're hoping that providing options for preserving your fertility gives you some autonomy about what to do with that information. So timing also matters for fertility treatment. You can see from this graph that there's about a 15% drop in IVF outcomes in the 2 years from 37 to 39 years of age. For every 18 months after 35 years, the chance of a birth per completed IVF cycle, so that's if you have an IVF cycle and then transfer all of the embryos that result from that cycle, drops by about 10% per 18 months beyond 35 years. So because of all of this, there's really growing interest in making a choice about freezing eggs before you're ready to have a baby. So social egg freezing is collecting and storing eggs in healthy, very fertile women in order to have a pregnancy at some point down the track. And by electively freezing your eggs, people hope to optimize the likelihood of successful live birth at a future date. But this isn't the only reason, of course, that people freeze eggs. I counsel a lot of people wanting to freeze eggs for medical reasons, either having cancer treatments or medical treatments that will reduce your ovarian reserve or that are not compatible with the pregnancy. So you have to delay a pregnancy until after treatment is complete, or people wishing to take advantage of gender affirming hormone treatment, which can and does impact the future chances of having pregnancies. So there's lots of reasons that people come to have a discussion about freezing eggs. So the reasons are really varied, but regardless of why you're considering it, the process is quite similar. So some facts about egg freezing. The age of your eggs reflects the age at the time you froze them, not the age, obviously, when you use them. And eggs freeze quite beautifully for a long time. And the age of your eggs at the time that you collect them is one of the biggest indicators of whether or not you'll go on to have a baby one day, not the age that you have the pregnancy. And while there have been huge advances in egg freezing, particularly in the freeze and thaw techniques, it's still not the really lovely insurance policy that we would like it to be. And it doesn't necessarily guarantee a baby. But as I've sort of said, preserving your fertility or having the option to have a discussion about it gives you a chance to have some autonomy over your fertility. There's limited data, but it's emerging about the success rates overall because fewer than 10% at the moment of patients actually return to use their eggs. So there is a lot of egg freezing happening in patients who then don't need to use their frozen eggs down the track. And what I'll cover towards the end of the talk is that it's worth considering the lab that you decide to have your treatment with, considering their overall IVF success rates, because eventually those eggs, the aim is to turn them into embryos and pregnancy. So I'm going to spend some time now walking through the steps involved in an egg freeze cycle. I've put a little pictorial representation of all the different steps of an IVF cycle. An egg freeze is part of the first couple of steps of a full IVF cycle. So an IVF cycle typically takes up to 3 weeks from the time of your first injection until your egg collection. Often it's sort of 9 to 16 days on average, though, for the egg freeze cycle, but a whole IVF cycle can take 3 weeks. This picture, when I see it now in front of me, looks rather busy, but it's a really nice diagram of all of the elements of an egg freeze cycle. So this is one of the more common cycle protocols that we use at the moment. So each month during a natural menstrual cycle, a woman recruits a number of immature follicles that are stimulated from hormones from the brain. So FSH is released from the brain. FSH stands for follicle stimulating hormone. It does exactly as the name suggests, and the ovary detects that and it stimulates a group of immature follicles that each month are laying in wait to be stimulated by that hormone. One of those follicles is a little bit more sensitive, and it's the one that becomes the dominant follicle and goes on to ovulate. That progressing dominant follicle releases its own chemical mediators in the form of hormones like estrogen, but it also releases inhibitory substances that cause the rest of that pool of immature follicles for that month to die away, not to be able to be used again. So it's a fairly kind of wasteful natural system. We hope to take advantage of that process and make it a little bit more efficient. So having an egg-free cycle doesn't prematurely burn through a heap of eggs that you wouldn't have used normally. It actually takes advantage of those eggs that you would have lost in the cycle if you weren't preserving eggs. So it does require daily injections of a man-made version of FSH, or follicle stimulating hormone. The cycle starts on usually the second day of your period, which is the second day of your cycle, which is the second day of bleeding, and you deliver to yourself daily injections of FSH that has been dosed perfectly for you based on your age, your weight, some blood tests, and some ultrasound findings. We then bring in a second medication that is either given in the form of an injection or a tablet that helps prevent the brain from wanting to override the process that we're trying to create. So we're trying to grow up all of those follicles together to be the same size all at once rather than one becoming dominant. And the brain will always want to ovulate off follicles as they're developing. So we bring in that second medication to quiet the brain down so that we can continue to develop those follicles all together without having them lost to ovulation. When we're watching how this process goes, we use a combination of blood tests and transvaginal ultrasound scan. The ultrasound, which is the black and white pictures that you can see, the first one, it's very difficult to see where the ovary is in amongst all of that sort of grayscale picture. And you can see as the pictures progress, the ovary becomes a lot more obvious. It's bigger. The big black dark circles within it are the maturing follicles. And by the time we are ready to collect those eggs, the ovary is much bigger and the follicles much easier to see. We also monitor blood tests, and in those bloods, we're looking for estrogen levels, which is released by those growing follicles. It also measures LH, another hormone from the brain, which gives us a clue if the brain suppression isn't adequate and can tell us if the body is trying to ovulate. And we look at progesterone levels. When all of those things line up beautifully and we look like we've got a good number of good sized follicles and the blood tests look good, that's when we plan the final trigger. The trigger is either given as a nasal spray or an injection, and it triggers the final maturation of the eggs within the follicle. And it also helps loosen up the tight connections that the egg has to the edge of the follicle to allow it to be a little bit more free floating within the follicular fluid, so that when one of the doctors, like myself, goes in with the needle for the collection, it's much easier to aspirate the egg with all of the fluid that we're collecting. The egg collection is the bit that's really time sensitive. So 36 hours after your trigger is when we collect the eggs. And I'll talk about that process in a little bit more detail in a moment. You can see from these pictures the process of ovarian stimulation and how the ultrasound images differ from just a natural cycle where you see those smaller follicles out to the edge towards the left of the screen of the top image, and the really big dominant follicle that will eventually release its egg for ovulation. A stimulated ovary, which is the one below, you can see there's lots of follicles and they're all a sort of uniform size rather than just one dominant follicle. So the next step in the process is the egg collection. 36 hours after that trigger, you are planned to come in through hospital. At Genea, we do all of our procedures jointly through Lingard Hospital. You come into the day surgery unit at Lingard and you're admitted. And then we have an adjoining little corridor to Genea where we bring you through to our procedure room to have the egg collection procedure under medical sedation. So your fertility specialist sees you and places a drip and gives you medication in the form of fentanyl for pain relief and midazolam for relaxation, to make you feel really calm and sleepy. And then we use a transvaginal approach with an ultrasound and a very fine little needle that places a lot of local anesthetic at the vaginal mucosa and at the peritoneal surface. And then we use a very fine needle into each one of those very dark follicles that you saw on the previous picture. And it's connected to a little suction device that sucks up the fluid and the egg with it. We always encourage you to have a support person present for that procedure, and you and your support person are actually able to see the screen that we can see, where you see each of the follicles being entered and the fluid being sucked out of it as the follicle collapses. The whole process from the time you come through to across the corridor to Janaea, have your drip and your medicine, have your procedure and your egg collection, and are going back through to Janaea, takes about 20 to 30 minutes. So it's not a long procedure. There is the option to have a general anesthetic and go completely to sleep, and there are some circumstances where that's much more appropriate. Our standard is for medical sedation with the medications I talked about, but each person needs their treatment plan individualized. We deliver oxygen during that process through little prongs in your nose, and we measure your pulse rate and your blood pressure and your oxygen throughout. There's a nurse there that's just there to make sure you're okay and your observations are fine and deliver extra medicine if you need it, as well as a nurse there that helps the doctor who's collecting the eggs. So the two of them are doing that procedure together. This is a picture of our procedure room at Janaea Newcastle. You can see the examination bed with the ultrasound beside it. And off in the right-hand corner, you can see the incubator, which is actually, I think, the coolest part of the whole process. In real time, while we're doing the egg collection, there is a scientist in the room with us. And as we're collecting the fluid from each of the follicles, the scientists are going through that fluid carefully under the microscope in a very controlled environment within that crib that's temperature controlled, looking for all of the eggs that we find. So in real time during the procedure, you are hearing back about how many eggs we're collecting. The egg's a pretty cool cell. It's the biggest cell in the human body. And when we collect it, the egg isn't ever by itself. The egg is this dark bit in the middle of that photo on the left, and you can see it's surrounded by a lot of sort of circular fluffy cells. And those are the cumulus cells, which are there to help with follicle development and help mature the egg and also provide some protection for the egg. And then over on the right, you can see the actual egg cell after all that extra stuff has been pulled away. So not every follicle gets to the size that's going to be appropriate for an egg collection. Not every follicle that we drain contains an egg, and not every egg, once we pull away all those supportive tissues, is mature and suitable for freezing. But you find out that information within sort of 24 hours of having your egg collection, the final number of how many eggs we were able to freeze down. So we always have one of the scientists speak to you on the day of your procedure or just after your procedure to let you know how many eggs we were able to find. So I'm going to move now to a bit of a kind of frequently asked questions. And if there's anything in here that is a question that you really would like, please interrupt at the end and ask it, and we'll come together as a group and get the most appropriate person to answer that question for you. So lots of people want to know, what tests do I need, and are there any tests you can do leading into your visit with your fertility specialist to make the appointment a little bit more streamlined? So your local doctor, or sometimes it's a fertility GP, can arrange a number of tests to work out your sort of baseline ovarian reserve, or to help inform the medication dosing that we use when we're planning your cycle. These investigations are in the form of blood tests and ultrasound scans. Some of them are timed with your cycle, and others can be taken whenever it's most convenient for you. So the first one that I want to talk about is an AMH. The AMH or anti-Müllerian hormone is a blood test. Everywhere in Newcastle, there is an out-of-pocket expense for this test. It's in the order of about $90 to $100, no matter which laboratory you have the test taken at. And AMH is a hormone that's expressed in the antral follicles or immature follicles of reproductive age women. The concentrations are really low in female kids until they hit puberty. And then the concentrations decline slowly again over the reproductive lifespan as the size of that pool of remaining small follicles decreases. The main use for us of AMH is to help estimate the ovarian reserve, but more importantly, to determine how responsive your follicles will be to the medication we use for ovarian stimulation that I've talked about earlier. So that FSH dose that we give you. It's not a perfect test. It tells us nothing about the quality of your eggs, which is far more determined by your age and overall health. But it does give us an idea because we can put it on the graph that I've got displayed as sort of averages based on age. And we can tell whether or not you fit within the sort of normal range for where we would expect it to be for age. And it gives us a guide as to whether or not you'll reach menopause in line with Australian averages, which is about 50 to 52 years of age. A really high AMH level, though, doesn't mean wildly amazing fertility. It's usually an indication of polycystic ovarian syndrome, or polymetabolic ovarian syndrome, which is, the name has been changed very recently. But those lower, really low levels do indicate sort of diminished reserve. Ultrasound's the other part of that puzzle. So we use AMH and an antral follicle count as sort of surrogate measures of your ovarian reserve together. The follicle count is when we get an experienced sonographer to count the number of follicles that are greater than 2 millimeters in each ovary in the early part of the menstrual cycle before you ovulate. So if we need it to be almost just at the very start, just after you finish bleeding from your period. We don't want you to have had a dominant follicle that's about to ovulate, and we don't want to look at the ovaries after you've ovulated. We need to look at that pool of immature follicles that are laying in wait to be stimulated that cycle. The antral follicle count can be impacted by the pill. It can suppress the ovaries down so much that it sort of gives an apparently lower count. And it can be influenced by polycystic ovarian appearance. So if there's polycystic, doesn't mean big cysts on the ovary that need operations. It means loads and loads of those little immature follicles. But the count indicates a number of follicles, but it again doesn't provide any information about the quality of the eggs. I get asked a lot about how many eggs should I freeze, and I know there are studies being done at the moment trying to help us work out a little matrix where we can put in people's individual factors like their age and their weight and a whole heap of, and their AMH and their follicle count, and work out what would be the best number of eggs to collect for that individual in order to optimize their chance of having a baby. But at the moment, we don't have really good quality information like that. So we do really individualize those numbers based on a person's individual characteristics. So my estimate for how many eggs we would get in a cycle will be very different for someone who's young with a really normal AMH range and a big antral follicle count, compared to someone who's a little bit older or who has a low AMH or a really low antral follicle count, or who's been unwell because of a medical condition. So we individualize those discussions during counselling. The average number of eggs that are collected per cycle sits somewhere between 5 and 15. In Janaea throughout Australia, the average number is 9. But it can be very different. Sometimes we will recommend to people to consider having more than one egg-free cycle in order to get a reasonable number of eggs, but that's a very, again, individualized decision. And we do recognize that there is a physical and a financial commitment to going down this path. And for some people, having one cycle is really all they want to do, and that's also completely fine. So part of the counselling you have with your fertility specialist is to take all of those results into account and give you a little bit of a sense about what we should aim for. The other thing to bear in mind is that there is always a lot of challenging loss in fertility cycles. You go into it with a sort of an idea of numbers and that we've given you. We measure follicle count during your tracking cycle, so you know how many follicles there are, but not, as I said, not all of the follicles contain an egg. And then you get a number of how many eggs we collected, but not all of those eggs are mature. And then when we come to use those eggs down the track, there can be some loss of eggs as they're thawed out. Not all of those thawed eggs that survive beautifully will fertilize when we put them in contact with sperm. And not all of those fertilized eggs will make it through the stages of embryo development, allowing them to get to the stage that is suitable for a transfer. And not every transferred embryo will make it to a pregnancy. And there's no getting around the fact that those phone calls and conversations, no matter how well you prepare yourself for them, it's always really difficult for us to hear that the numbers have dropped down, even when we theoretically know that that's possible. The other question that I get commonly asked is what age is best? So based on what we know about egg quality decline with age and the evidence that's emerging about successful pregnancies after egg collection, we do recommend that sort of the best age to consider this is at or before the age of 35, but there's still excellent evidence to suggest that egg freezing can be really beneficial as well as cost effective up to the age of 39. Ideally in a perfect world, the sooner the better, but again, it's a big financial and physical decision. So it really has to be undertaken if and when it feels like it's the right time for you. And we want to kind of always achieve that sweet spot where we're doing this, particularly if it's not for a medical indication that forces our hand in terms of timing, but we're doing it at a time where you're less likely to find that you're falling pregnant in the next couple of years after we do the egg freeze, and you don't ever need to use the eggs versus waiting too long and we've lost some of that egg quality that we would have liked to capture. I popped this up for some up-to-date egg freezing cycle costs. The egg freeze cycle cost doesn't attract any Medicare rebates, unfortunately. So the cycle cost is just over $5,600, which equates to the out-of-pocket expense. But there are some extra little bits that aren't mentioned in the overall cycle cost. There are medication fees as well as storage fees, which are about $55 per month for storage. There are hospital admission fees, which depend a little bit on whether or not you have private health insurance that covers these kind of cycles. If you don't have private health insurance, the admission fee through Lingard Hospital to have an egg collection is just over $2,000. But when you come into, prior to signing up to any of this, there's lots of opportunities to have thorough discussions with the accounting team to talk through what the costs will look like for you individually. How long can you freeze your eggs? The short answer is as long as you need us to. Different clinics will have a different default length of time outlined in the consent forms and contract that you sign with the clinic. In Newcastle, that is 10 years. In Sydney, it's 15, but you can individualize this at the time that you sign up, or you can extend the storage time by writing to the unit closer to the end of your storage time. And locally, we've not yet needed to extend the storage for anyone, but we imagine it's coming as increasing numbers of people are coming through to have egg-free cycles. I did have some feedback for the last talk that people wanted to know about the possible complications of an egg-free cycle, so I'm going to spend a little bit of time talking about that now. The complications that I usually tell people about involve the cycle itself and then the medical complications of the procedure, which is the egg collection. So I'll start by the cycle first. Um, there is always a chance that when we titrate that medication dose based on your individual features, that we get it wrong and we have underdosed you and your ovaries don't respond in the way that we had thought they would. And things don't line up that month. And we don't always want to put you through the physical and financial aspects of an egg collection if we think we'd be able to do a much better cycle. So that's called a cancelled cycle, where you're taking your medication beautifully, you're tracking along and you're having your blood tests and your scans. And when we get those results, we realize that the ovaries just haven't responded to where we would like them to be. And we have a discussion with you about cancelling that cycle, regrouping next time with a higher dose of medication and starting again. The other thing that can happen is the other end of the spectrum, where we can overdo the dosing and cause something called ovarian hyperstimulation syndrome. So that's a cluster of symptoms where the ovaries are very stimulated, a lot of follicles develop at the same time, and developing ovarian follicles release sort of vasoactive substances that make your blood vessels a little bit leaky. You can get fluid accumulating in places where it shouldn't be. You feel quite bloated and very constipated, and you can have pain in the tummy. And you can need hospital admissions for supportive care like anti-nausea medication, pain relief, and daily monitoring of your fluid balance. Ovarian hyperstimulation that requires significant hospital assistance is now uncommon in Australia because of the new protocols that we use. There's usually only 1 in 200 patients that will develop that. So we've gotten much better at predicting it and managing it. So that's the cycle component. In terms of the egg pickup procedure, there's always a chance that you can have an allergy to the medications that we use to help you feel relaxed and comfortable, but that's very uncommon. And we're attached to a fantastic hospital with lots of help close by. There are some structures that are precious that sit really close to your ovaries, like blood vessels, the bladder, and your bowel. And we do this under ultrasound guidance in order to watch where we are and carefully consider where we place the little aspiration needle to empty those follicles. The chance of a vessel injury that requires a hospital stay or operations or a blood transfusion is very, very, very low. The chance of an injury to the bowel that requires hospitalization or operations or can impact your fertility is also very low. This is a procedure that we are good at, that we think about really carefully, and that we spend a lot of time thinking about and watching the structures close to where we're operating, and we've become very good at. But with any medical procedure, there are risks that should be considered and should be discussed with you before your procedure. If you're having an egg freeze for medical treatment or for social reasons and you're not ready to have a family and you've been on some contraception, I should mention a little bit about whether or not you can stay on that contraception while we do the cycle. So for people who are on the pill, we take you off the pill for the cycle period. You can start the cycle as soon as you have a bleed from the pill, and sometimes we do use the contraceptive pill to time the cycle. And sometimes we'll talk to you about being off the pill for a couple of months before we cycle, but it is possible to be on it right up until you have your egg-free cycle and then to recommence it once the cycle's finished. Depo, Provera, and the Implanon are quite suppressive, so we can override that with big doses of FSH, but our preference where possible is that we have a little bit of a washout period and cycle without them on board, but it is absolutely possible to do it with them in place if that was your preference. A Mirena can stay in, does not impact the cycle at all. We can also place Mirenas at the time of egg pickup for those people who've been considering it but just haven't sort of gotten around to planning it, and we take advantage of the fact that we've given you really nice sedation and we can place the Mirena at the same time. But you can absolutely leave it in through cycling. It does get a little bit difficult to work out when to start the cycle with Mirena because we can't be guided by your normal bleeding for those people who have lovely menstrual suppression with the Mirena, but we can use blood tests instead, and we wait to see you when you're at baseline, and then we base the cycle on your blood test rather than your bleeding. And how do I choose where to have treatment? Again, this is really individualized. We're obviously working through Newcastle Fertility Specialists, and we're affiliated with Genea, and we're super proud of that. But there are other fertility clinics that offer this service. I had had a choice of where to work, and I chose to align with Genea because I loved the team. I loved the gynecologists that I got to work with in rooms. I trust all of them for taking care of my patients when I'm on leave, for clinical advice and mentorship. So for me, it was really easy. This is our team here at Newcastle Fertility Specialists. We have 4 female gynecologists that all specialise in infertility. There are appointments available usually within 4 weeks. They can be in person. We do phone or telehealth appointments and hot doc appointments based on your preference. We offer the full range of infertility treatment, including egg freezing, obviously, but also ovulation induction for those people wanting a pregnancy, preconception advice for people who have things that need to be considered before they plan a family, testing whether or not your tubes are patent, endometriosis, workup and surgery, as well as surrogacy, donor and IVF. We've got sperm donors available from local and overseas banks. We all operate through Lingard Private Hospital, but Kate and I have access to public operating lists through John Hunter and Belmont hospitals. The team is all about finding the one that's right for you, and you do need to feel confident and comfortable with your specialists. But also the success rates change depending on the laboratory that you align with. The team at Newcastle involves embryologists and andrologists. We have counsellors, beautiful administrative staff on the front desk, an incredibly skilled group of nurses, and a clinic manager that is across everything, and an accounts team that are remarkably accessible. So it's very individualized who you want to choose for your journey, but for me, I was really proud to align with Genea. You can look up clinic success rates yourself. There's a really cool website that's government funded. It's called Your IVF Success, and it actually has 2 functions. So you can look at individual clinical success rates, but you can also, I know we're talking about egg freezing and not IVF, but there's also an IVF success estimator that gives you a sense of your chance of a pregnancy after a completed cycle if you pop in some statistics about yourself and your partner. But it also compares success rates of all of the clinics, or most of the clinics throughout Australia. And Genea does really well. It performs in always the top 3 of clinics consistently, which is quite cool. So Genea is the one in blue, and you can see the best low-cost clinic in New South Wales, the national average, and Hunter IVF also displayed in the other tables. And we do very well for live birth rate per egg collection in both the under 35 and the 35 to 42 years. And I've also popped in this one for live birth rate per embryo that we transfer. So your chance of having a baby each time that we transfer an embryo, broken up comparing those same clinic groups in the less than 35, 35 to 38, and then the greater than 38 years. And you can see we do really well. And that success does add up. So the number of babies born per 100 new patients after 2 cycles of IVF, if you're less than 35, is displayed here. And you can see that if you are under 35 and have 2 full cycles of IVF using all of the embryos from those cycles, there's about a 90% chance of having a baby with our Newcastle team, which is considerably higher than the other groups. So to summarize today, I just wanted some take-home messages, which are that egg freezing isn't an insurance policy, whilst we'd love it to be, and it doesn't guarantee a baby later in life if fertility is delayed. But where previously there just were no options for women who weren't ready for a family, now we have the chance to have a conversation, to gain information, and then to use that information to make the choice that's right for us. And the choice about whether we go ahead or don't go ahead isn't the bit that matters. It's being able to get that information in the first place. It has been shown to be cost effective up to and including 39 compared to starting IVF if you're 40. Ideal timing is less than or including 35 years, but we can do egg freezing at any age. The average number of eggs that we expect for each cycle really depends on your individual factors, and that's something that your fertility team will talk to you about when you have a visit. And sometimes your specialist recommends more than one treatment, but that is treatment cycle, but that is always up to you about whether or not that's what you would like to do. So that's all I have today for the formal part of the chat. I was hoping now to just open it up to questions if anyone had anything that I hadn't covered or that you wanted a little bit more information about, or if you wanted to take advantage of Brooke or Carissa or Lisa being present tonight.